Honorable Chairperson and respected Principal, Holy Paper Redcrescent Medical College and Hospital, Professor Major Teacher Harun Sir, Honorary Secretary of Bangladesh College of Physicians and Surgeons, Professor M.A. Jalil Chaudhary Sir, who is my direct teacher, Professor Abhana Mustafa Kamal, Professor in the Department of Medicine, Holy Paper Redcrescent Medical College and Hospital, distinguished doctors, my interns and students. So my topic of discussion is liver disease in pregnancy, and this is a vast topic. And in a very short span of time, it's not possible to complete all segments, but I'll try to complete. So why liver disease in pregnancy is important? Because there is constriction of mind. As in pregnancy, there is no relaxation and it is full of anxiety and fear. There is dilation of the heart because of cardiomyopathy, proteinuria, blood is toxic, there is bloody sensation in the body because of edema, abnormal liver function test as the liver is fatty. So this is the pregnancy, and our topic of discussion is liver disease in pregnancy. So what is the condition of the liver in pregnancy? There is blood flow is normal, excretory function of the liver is reduced, there is increased bile salt in the last trimester, serum alkaline phosphatase is increased but albumin level is reduced. Why the liver disease is concerned in pregnancy? Because liver disease itself is a high risk condition. Pregnancy is a vulnerable condition. So risky and vulnerable condition leads to a red alert situation. So why in pregnancy liver disease occurs? There are several hypotheses. Some say that it is due to humoral change, placental hormones, autoimmune mechanism, cholestasis, uterine stretching, or it may be due to other factors. So we are swimming in the sea of enigma, where we are searching in the dark with a beam of light. So what are the types of liver disease that usually occurs in pregnancy? Liver disease specially related to pregnancy. Liver disease coincidental to pregnancy, pregnancy superimposed on pre-existing liver disease. So liver disease specially related to pregnancy means pregnancy is a triggering factor for the development of liver disease. Here, the prototype diseases are hyperemesis gravidarum, intrahepatic cholestasis of pregnancy, acute fatty liver of pregnancy, hepatic dysfunction associated with toxemia of pregnancy. Liver disease coincidental to pregnancy. That means a pregnant lady suddenly develops liver disease. Those are hepatitis, amoebiasis, and other infections of the liver, Budd-Chiari syndrome, gallstone disease, and hepatic tumors. Pregnancy superimposed on pre-existing liver disease. That means a lady is having some liver disease, but suddenly she becomes pregnant. Those are chronic hepatitis, cirrhosis of liver, extrahepatic portal vein obstruction, primary biliary cirrhosis, familial hyperbilirubinemia, Wilson's disease, and porphyria. Now, the liver disease specially related to pregnancy. Hyperemesis gravidarum, all are very much acquainted with this condition. Usually it occurs in the first trimester. It is associated with nausea, intense vomiting, dehydration, malnutrition, and some say that increased level of steroid hormone is the mainstay for this condition. Hepatic dysfunction in severe cases. 25% of the hospitalized patients develop abnormal liver function test. AST or LT not so high. Histology of the liver shows normal, or there may be microvesicular fatty change. Removal of the stressful environment, rehydration, replacement of the vitamin, antiemetics, and total parenteral nutrition is the mainstay of treatment in hyperemesis gravidarum. Liver function test returns to normal by correction of dehydration and malnutrition. Occasional premature labor or perinatal death may occur. Intrahepatic cholestasis of pregnancy. This is a very important condition associated with pregnancy, and we frequently get consultation from gynecology department. It is one of the important causes, and about 20% cause of jaundice in pregnancy. 70% occurs in third trimester and among the multiple women. There is familial association. Predominant causes impairment of microvilli movement in biliary canality and leading to stasis of bile flow. So, predominant clinical feature is pruritus, mostly in hands and feet, and there will be nocturnal severity. Pruritus develops in third trimester, and 15 to 20% of pregnant lady having pruritus may develop jaundice. So if a pregnant lady presents with pruritus and jaundice, how to assess? First jaundice, then pruritus, acute hepatitis. Jaundice and pruritus simultaneously, obstructive jaundice. First pruritus, then jaundice. If the jaundice 2 weeks after pruritus, intrahepatic cholestasis of pregnancy. If jaundice months after pruritus, then primary biliary cirrhosis. So laboratory investigation, serum alkaline phosphatase is markedly raised, gamma GT is raised, and there will be prolonged malabsorption. Now, if a pregnant lady presents with pruritus plus minus jaundice, and there is elevated alkaline phosphatase level, elevated transaminase level, what to do at first? As a physician, after assessing clinically the patient, we should do an ultrasonography. Ultrasonography may give three types of liver architecture. It may be normal, there may be accumulation of fat, and there may be dilated bile ducts. If the liver architecture is normal, the condition is suspected to be intrahepatic cholestasis of pregnancy. Then if there is steatosis or accumulation of fat, acute fatty liver pregnancy. If there is dilated bile ducts, then bile duct disease or gallstone. So in case of intrahepatic cholestasis of pregnancy, treatment is ursodeoxycholic acid. In case of acute fatty liver pregnancy, since it is a life-threatening condition, emergency delivery. And in case of bile duct disease or gallstone disease, conservative management of drainage by ERCP. So management goals of intrahepatic cholestasis of pregnancy is reduce symptoms in the mother, provide an adequate obstetric care, prevent fetal distress or sudden fetal death. Care of the fetus is very important. It is done by close fetal monitoring and elective delivery at 37 weeks. So, what is the prognosis of intrahepatic cholestasis of pregnancy? Usually, pruritus disappears 2 to 7 days after delivery. Jaundice disappears 1 to 2 weeks after delivery. No obstetric complications during labor except increased postpartum hemorrhage. Now, acute fatty liver of pregnancy. This is a very life-threatening condition, common in primary and incidence worldwide, associated with preeclampsia in 30 to 60% cases, and some says that there is long-chain 3-hydroxyacid coenzyme deficiency. Sudden onset of nausea and vomiting in the third trimester in 70% of the cases, upper abdominal pain, flu-like symptom, jaundice occurs 1 to 2 weeks after onset of the symptoms, pruritus is rare here, and liver is rarely palpable. So if a pregnant lady presents with jaundice with shrinkage of the liver, then if the liver is not palpable, we should suspect it might be a case of acute fatty liver pregnancy. Laboratory findings. Serum bilirubin is markedly raised, but AST is not so high. It never reaches more than 1000 international unit. DIC is common. There is profound hyperglycemia. Renal dysfunction may occur. Histology shows centrilobular microvesicular fatty infiltration of the hepatocytes. This is the histological findings of acute fatty liver pregnancy. We see zone 3 hepatocyte full of microvesicular fat droplets. Complications are cerebral edema, GI hemorrhage, renal failure, coagulopathy, hypoglycemia. Management is early recognition and prompt delivery. In severe cases, ICU support is essential. Aggressive management of complications, liver transplantation may be necessary if fulminant hepatic failure develops. Pregnancy toxicness and liver. Pre-eclampsia, eclampsia, HELLP syndrome or HELP syndrome, infarction of the liver, bleeding and rupture of the liver, all are included under the heading of toxic pregnancy where the liver is affected. We all know what eclampsia, preeclampsia is. There is hypertension, proteinuria, peripheral edema. It usually occurs in the second and third trimester, common in nulliparosome. Liver is affected in 20 to 30% of the cases. So what happens in the liver during eclampsia? There is arteriolar constriction, vascular endothelial damage, platelet deposition, fibrin deposition, eventually leading to the development of thrombocytopenia, ischemia, necrosis, and hemorrhage of the liver. This is the liver in eclampsia. Now, HELLP syndrome or HELP syndrome. There is hemolysis, elevated liver enzymes, and low platelet. RBC breaks, hepatocytes cracks, and platelet breaks. So this is the RBC in HELLP syndrome, liver in HELP syndrome. This is the liver, this is the stomach. Now, it first reported in 1954. 4 to 10% of the preeclamptic pregnancies HELP syndrome occur, commoner in older and multiparous women. HELP is no more than severe eclampsia. In fact, this is a grave complication of preeclampsia. Possible etiology, several hypotheses have been postulated, but none are still proven. So, what are the clinical features? Nausea, vomiting, epigastric and right upper quadrant pain, headache, visual disturbances, hepatic tenderness, edema, ascites, and there may be proteinuria. So, diagnostic features of HELP syndrome are hemolytic anemia, elevated liver enzymes, and thrombocytopenia. Usually, platelet count is less than 1 lakh per milliliter. So what are the DD or differential diagnosis of HELLP syndrome? Hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, ITP, and systemic lupus erythematosus. So a pregnant lady with all this system, all this condition may mimic with the presenting features of HELLP syndrome. So complications are DIC, abruptio placenta, acute renal failure, pulmonary edema, perinatal mortality, maternal mortality. So treatment. ICU facilities both for mother and neonate. Prompt delivery usually recommended. Treat thrombocytopenia and coagulopathy as necessary. Consider steroids and magnesium. Rarely, women deteriorate post-delivery. So there is overlapping between preeclampsia, HELLP syndrome, and acute fatty liver pregnancy. So it is very important for the part of the clinician to differentiate all the three conditions. So liver disease is coincidental to pregnancy. That means a pregnant lady, if suddenly becomes affected with liver disease. Viral hepatitis. We all know most common viruses are hepatitis A, B, C, D, E. All invade the liver and cause inflammation, results in the destruction of the liver cells, differ in terms of mode of transmission and outcome. Now, HEV in pregnancy, this is very important, may precipitate fulminant hepatic failure. It is indistinguishable from acute fatty liver of pregnancy, 50 to 10% vertical transmission, and HEV RNA may transmit from mother to the fetus, 20 to 28% maternal mortality in Asian countries, 50% fetal mortality. So this is a very important clinical condition in the context of pregnancy. Now, hepatitis B virus. HBV transmission in pregnancy. First and second trimester, minimal transmission, but in third trimester, transmission occurs invariably. Perinatal transmission, 70 to 90% if the mother is HBeAg positive, and HBs positive only positive mother, 22 to 67%. Now, management of hepatitis B virus in pregnancy, still it is unresolved issue. Every year, Association for the Study of the Liver, America Association Study of the Liver, Asia Pacific Zone, they produce guidelines, but still not a definite treatment has been produced for clinicians. However, the management guidelines according to the Asia Pacific Association for the Study of the Liver, last March there was a conference in New Delhi. Their guideline is pregnant women while on oral antiviral drugs can continue treatment. Pregnant women who need treatment can be treated with category B drugs like telbudin and tenofovir for the prevention of mother to child transmission. Pregnant women with high DNA can be treated with tenofovir or telbudin in third trimester. Treatment is recommended with lamivudine in case of impending liver failure. Interferon-based therapy is preferred for non-pregnant women. Pregnancy is discouraged during interferon therapy. HCV in pregnancy. Hepatitis C virus infection is not contraindication for pregnancy. No adverse effects on pregnancy and its outcome. About 6.9% of infected mother transmit to newborn babies. HCV is detected in breast milk. Breastfeeding is not risky for transmission. Treatment is not recommended during pregnancy and lactation. Now, what is the take-home message from my speech? Liver disease in pregnancy is a red alert situation. Pregnancy itself is a precipitating factor for the development of liver disease in pregnancy. Intrahepatic cholestasis of pregnancy is the leading cause of pregnancy-associated liver disease. Acute viral hepatitis is the commonest cause of jaundice during pregnancy. Hepatitis B virus and C virus infection is still an unresolved issue in the context of pregnancy. Thank you so much.